Assalamu alaikum students and welcome to your ophthalmology lecture video sessions. Today we'll be talking about keratitis, which is our second differential in the theme of the red eye. This is the first differential that we'll do that is really associated with pain and proper pain, not just foreign body sensation or discomfort, pain. So this is what we are going to be talking about today. We talk about corneal structure and function, the types of keratitis, how they present, how we manage them, and their complications. Keratitis is important because it can be considered to be an ocular emergency. Though it's not life-threatening, it is sight-threatening. So we'll talk about the structure and function of the cornea first, and before we get on to the nitty-gritty of it, this is just a anatomical overview of what the cornea is, and it's basically the anterior 1/6 of the outermost coat of the eye. It's your window to the world. It transits from the sclera at something called the limbus, which is sort of grayish in color, and the conjunctiva covers the sclera, does not cover the cornea, neither does the episclera. We talked about it when we were doing conjunctivitis. So this is histological structure of the cornea, and the cornea has a multi-layered stratified squamous epithelium of the non-keratinizing variety. Its characteristics are it heals without scarring, and number two, it has a rather rapid regrowth, and it is a first barrier that you have that prevents infections from occurring in the cornea. Then we have the Bowman's layer. Bowman's layer is just a sort of a thickening of the stromal layer, and it is the layer that gives the cornea its characteristic bow-like shape. It's not called Bowman's because of that. Bowman's is after a name. So the stroma is the bulk of the cornea. This is the main refractive medium of the cornea, and this has transparency because of the way the collagen fibers are arranged within the stroma as specific thickness bundles so that they allow light to pass through. This is the place where your infective organisms want to reach, because this is the place which has the proteins which these organisms need to replicate. And remember, the only reasons these organisms, if we are talking about an infectious keratitis, they want to get here is because they want to replicate. Like all living things, procreation is the ultimate aim, and those organisms are coming here just to increase their number. The thing about damage to the stroma is, which is an ulcerative process. We'll talk about a difference between an ulcer and an erosion in a bit, is that it heals by scarring. So if you have trauma or damage to the stroma, it will heal, but it will develop a scar, so you will lose your corneal transparency. Finally, we have the Descemet's membrane and the endothelium. The Descemet's membrane is the basement membrane of the endothelium. So although the cornea is supposed to have 5 layers, it is essentially, you can sort of reduce it down to 3. You will have your epithelium, your stroma, and your endothelium. The endothelium basically is the side that's facing the anterior chamber. It's surrounded by aqueous, and it has these really special sodium-potassium pumps that helps in keeping the integrity of the cornea and the clarity of the cornea. The endothelial cells, once destroyed, they don't replicate. The surrounding cells sort of enlarge to take up a space, but they have a limited capacity to do so. So if you lose enough endothelial cells, you will lose the pumping ability, and you will have loss of clarity of the cornea. We talked about this when we did cataract, and one of the complications of cataract surgery was post-operative corneal edema, which was because of excessive instrumentation or other processes that caused loss of these endothelial cells. So what is preventing your cornea from becoming infected? Your cornea and your eyes are, as long as your eyes are open, your cornea is always facing everything that's in the environment. So there must be something to it that it's so well protected, it doesn't usually get infected. I mean, if you think about it, I'm sure lots of you have had sore throat, which is protected by so many things. Your throat by the lymphoid tissue, the saliva, and all of that, all of the other structures together with these, but you still get a sore throat in spite of all this protection. But I'm sure none of you have had an infective keratitis. Why is that? It is because your cornea is really well protected by a number of mechanisms, and we'll begin by lashes and tear film. Lashes and tear film, and even your brows, they form physical barriers. Brows prevent things from dropping down from your forehead onto your eyes, so there's a physical barrier. Your lashes trap a lot of things, those are a physical barrier. Your blink reflex, which is something that I'm sure everybody overlooks, is such an important barrier because every time you blink, your tear film is clearing things from the eye. And blink is also a protective response because it prevents things from going into your eye. When you see something approaching you, you can sort of close your eyes or you can blink. Together with that, you have your tear film, and tear film has lysozymes, immunoglobulins, which are again protective in nature. Then we move on to conjunctiva. Conjunctiva itself has something called CALT, which is conjunctiva associated lymphoid tissue, which is something like malt for your conjunctiva, which is basically something that provides a lot of defense cells. Remember, your cornea is avascular, so it depends upon the surrounding tissues and surrounding structures for assistance, of which conjunctiva is one. Together with that, conjunctiva also has a lot of commensals which prevent other organisms from coming in and causing issues. Commensals are those organisms that are living on another living organism, and they're mutually beneficial, or at least one of the organisms is benefiting and the other is not getting harmed. The conjunctiva also has a lot of mast cells. We talked about this when we talked about allergies, conjunctival allergies, allergic conjunctivitis. And those mast cells here would increase vascular permeability, allowing more defense cells to come in once you have an infective bacterial keratitis, bacterial or otherwise. Then you have the cornea itself, which has this epithelial barrier. We've already talked about it. And cornea also has lymphocytes and Langerhans cells. Those are sort of macrophages that are present in the limbus, and they're sort of, what's the word for it? They are dormant, and they would become active once the cornea is inflamed. So once you have a defect in one or more of one of these barriers, then it is very likely that you'll get an infective keratitis. Otherwise, your cornea is very well protected. So this is what it is. It's a very fine balance between what makes your tissues weak and what makes your tissue or your cornea protected. So it's the same set of factors that we have talked about before: your tear film, your corneal epithelium, the presence of commensals, your immune system generally, and the blink reflex. They're all protecting you. Your tissue health, i.e., your cornea may have had prior trauma because of the way you work, you're wearing contact lenses and you're not taking good care of yourself. Your general health, your immunity might be poor. You are diabetic, you have one of those immunocompromised disorders. When I mean you, I mean the patient or the person who might potentially get a corneal infection. The organism might be very strong, the virulence of the organism. For example, Pseudomonas can be devastating for the eye. Neiserial conjunctivitis, if not treated properly, we talked about neiserial conjunctivitis when we talked about conjunctivitis, the hyperacute variety. If you don't treat it properly, it can convert into a keratitis. And simply, if the virulence is sort of not the issue, the load, the pathogenic load might be so much that it will just overwhelm your defenses. So it's a very fine balance. If you get external protection and you have a corneal infection, then you might save the tissue. However, if the organism is able to replicate and establish itself, then the tissue might be lost. And we'll see both of these pathways as we talk about infectious keratitis. So what is keratitis? Keratitis is basically inflammation of the cornea. It could be of an infectious variety. It could be of a non-infectious variety. Infectious is usually central, away from the limbus, but that is not always the case. And the non-infectious variety is usually limbal, but again, that's not always the case, and they're usually associated with some form of autoimmunity. We have seen or talked about one type of non-infectious corneal ulcer, the shield ulcer, in reference to vernal keratoconjunctivitis as an example of non-infectious corneal inflammation. Before we talk about the disease proper, it's important to differentiate an ulcer from an erosion by definition as well as by appearance. So this is a diagrammatic representation of the cornea. I mean, both these pictures. This is the epithelium, this is the stroma, And this is the basement membrane of the epithelium. So I've just highlighted the basement membrane here because the other structures remain the same. It's highlighted here because it's going to show the difference between an abrasion and an ulcer. So an abrasion or an erosion is a lesion that is above the basement membrane of the epithelium. So it's limited to the epithelial layers itself. And it heals rather quickly. So the start of the healing process is usually between 24 and 48 hours, and between 5 and 7 days, it's as good as new, and it heals without scarring. When you want to see it, it stains with fluorescent dye. We have talked about fluorescent dye before when we talked about diabetic retinopathy, age-related macular degeneration. It's the same dye that you use to take FFA, fluorescent fundus angiography, the same dye that you use to stain the TF film when you're taking the pressure. And the same dye is used here, and it sticks to areas which does not have an epithelial covering over it. So it'll stain because there is no epithelium here. It's a defect. Epithelium defect is present, so it'll sort of pool in this area. The dye would simply accumulate, and you will be able to see this defect because of pooling and staining both. Now we have an ulcer. An ulcer is a lesion or a defect that extends to below the basement membrane of the epithelium. Thus, it extends into the stroma. And it incites a relatively strong inflammatory reaction simply because it's a deeper defect and it requires to be taken care of before the stromal damage increases. So it does incite a rather strong inflammatory reaction, and it heals by scarring. It will also stain by fluorescent dye simply because there is no epithelium cover over it. Their epithelium is damaged. So an ulcer is deeper. It extends below the basement membrane of the epithelium, whereas an erosion or an abrasion is something that remains within the epithelial layers above the basement membrane of the epithelium. Both of them will stain with the fluorescent dye. So this is an abrasion seen with the white light. Fluorescent dye, as we talked about, is fluorescent. You excite it with one type of wavelength and it will emit another. So when you see it in a white light, which has blue light, it's basically excited by blue light, but white light has all the wavelengths into it, those 7 visible spectrum wavelengths. It appears like this, but when you excite it with blue light, it emits green. And if you excite it with just the blue wavelength, look how clearly you can see the outline of the erosion or the abrasion. The other thing that tells me this is an abrasion, in addition to the staining, remember an ulcer would also stain, is I can see through this lesion. I can see the inferior border of the pupil. I can see iris details. That tells me there isn't much inflammation going around in the bed of this lesion. If we see an ulcer, it also stains with fluorescent. And if I just compare this picture to this picture, it's very difficult just by looking at a picture which is specially taken in a blue light with a corneal staining. It can be difficult to figure out it's an ulcer or it's an erosion. But if you look at the lesion under white light without stain, you can't see through the lesion. You can't see through the lesion simply because there is a lot of inflammatory reaction in the base of the lesion. If you have inflammatory reaction in the base of the lesion, you won't be able to see through it like we were able to see through our abrasion or erosion. So that's the difference between an ulcer and an abrasion. And when we talk about keratitis, we talk about formation of an ulcer, because remember, the organism needs to get into the stromal area to sort of be able to replicate really fast. So we'll take up infectious keratitis, which is the bulk of keratitis that you see. And first, we'll talk about the various pathogens that can cause infectious keratitis, and they are bacteria, fungi, viruses, and parasites. Bacteria are the most common organisms that are isolated from an infectious keratitis. Fungi would cause a keratitis, but they would require certain very specific conditions to cause that. Viruses usually do cause a keratitis, but as a secondary infection. We talked about viral conjunctivitis, and we talked about primary infections, if you remember our discussion of conjunctivitis. And then parasite. Parasite obviously would require contact with a contaminated fluid that contains the parasite. So we'll take up bacteria. Again, we have talked about it being the most common reason for most common isolate from an infective keratitis. And the most common reason is contact lens wear. And after that is direct trauma to the cornea, which is responsible for a bacterial keratitis. And the way it happens is this physiologic and traumatic damage to the cornea, the barriers that we talked about, the epithelium especially, when you damage it, you're giving organisms that are around you a chance to get into the cornea, and in a cornea that's sort of compromised because one of the barriers is damaged. We'll see the sources just in a bit. Where do these organisms come from? The most common organisms that you see is a Staph aureus. A Staph epidermidis will cause Staph epidermidis is something that lives on the skin, and it usually does not. It's of low virulence, but if you're immunocompromised or your cornea is immunocompromised, when I say your cornea is immunocompromised, it's a cornea that has previous damage. Your patient generally is in an immunocompromised state. So Staph epidermidis is something that can cause a keratitis. Strep pneumoniae, Pseudomonas is the most common gram-negative isolate, and it also causes a very rapid destruction. It is able to completely destroy an eye and make an eye non-seeing. We'll see some pictures that will show us what Pseudomonas can do to the eye. Neisseria can also cause a keratitis. This is a conjunctivitis. Remember, hyperacute bacterial conjunctivitis that causes a keratitis. And one of the interesting things about Neisseria and certain other organisms is they don't really need an epithelial defect to enter into the stroma. They can just penetrate an intact cornea, which is a very interesting habit of certain organisms. So where do these organisms come from? External is the most common route and can establish themselves. One of the barriers is compromised. Commensals, immunocompromised, and conjunctivitis, we have talked about that when you have hyperacute conjunctivitis, it can sort of, and if you improperly treat it, it can convert into a keratitis, and the organisms can penetrate an intact corneal epithelium and go into the corneal stroma. We're moving on to fungi and fungal keratitis, and fungi or fungal keratitis is more common in the developing world as compared to the developed world. This is a rather diplomatic way of saying that those underdeveloped agrarian economies are more prone to getting a fungal keratitis rather than those really developed Western and Northwestern economies. It is what it is, and we are an agrarian economy. Most of our economy revolves around agriculture. And so we should be seeing a lot of fungal keratitis. We don't. It's not that because we don't get it. It's because I think, and this is a personal thing, is that we simply don't have the diagnostic ability, and our reach of good ophthalmic services usually does not extend to areas where you have the agrarian base. So why agrarian? And that is simply because fungi are saprophytes. They survive on dead organic matter. They don't eat living things, they eat dead things. And dead organic matter is usually somewhere where you have a lot of crops or fields, a lot of agricultural activity, and thus the association between the two. The organisms you see are Fusarium and Aspergillus in tropical climates, us, and in temperate climates, it's Candida. And the source is again external and is workplace related, as we just talked about. Then we talked about viruses. Viruses cause a secondary infection by a virus causes a keratitis. The two most common viruses are herpes simplex and herpes zoster. We talked about adenoviral keratitis when we talked about conjunctivitis, and that's in a very specific circumstance. And you can refer back to the conjunctivitis if you want to see it. But keratitis proper, or keratitis by itself, is a secondary infection caused by a herpes zoster or a herpes simplex. The primary infection by herpes simplex is a conjunctivitis. Again, we talked about it when we talked about conjunctivitis. And recurrent infection causes a viral keratitis. And the triggers that makes the virus attack the cornea is basically stress, aging, and an immunocompromised state. A herpes zoster primary infection is chickenpox, Varicella zoster, those things that you get as a child. And then the virus becomes latent in the sensory ganglions, and to the eye, the sensory ganglion of the fifth nerve or the trigeminal nerve is important because the sensory nerve to the eye is the trigeminal. And it reactivates once the patient is immunocompromised, old, or ill, about the same things that is true for the herpes simplex virus reactivating. And in a herpes zoster keratitis, you have eye involvement as well as skin involvement. possible skin involvement. And if your eye and skin are both involved in a herpes zoster infection, it's called a herpes zoster ophthalmicus. And we'll see these when we talked about how these patients present. The organisms are herpes simplex and herpes zoster. And for herpes simplex, it's a recurrence of infection. For herpes zoster, it's the dormancy in a sensory root ganglion that sort of reactivates because of the reasons that we just talked about. Parasites, and it is basically a protozoal keratitis, and it is less common than a bacterial and a fungal keratitis. And the most common way of getting it is a contaminated contact lens solution. Others include exposure to contaminated freshwater source, swimming pools, hot tubs, saunas, and homemade contact lens solutions. Yes, there are wikis and WikiHows, not necessarily the WikiHow website, but other similar websites that tell you how to make a contact lens solution at your home. And you just might be using contaminated water as a source, and you can get a parasitic keratitis. The organism is Acanthamoeba. It's a free-living protozoa. It can survive in the soil, it can survive in water as well as air, and it exists in a trophozoite state, which is the active state, and a cystic stage, which is the dormant form. The source for a keratitis is contaminated fluid or contaminated powder, which is water, which is either your contact lens solutions most commonly. And in the US, I think it was late 90s, early 2000s, when they had a lot of problems with contaminated contact lens solutions causing a lot of bacterial keratitis and acanthamoeba keratitis. And I think the source of those contact lens solution was India, South Asia. So now that we know the organisms, let's talk about the pathogenesis and the patient presentation of an infective keratitis. And this pathogenesis is like any other inflammatory reaction in response to an invading organism. And the first thing that you need is obviously your microorganism, which, as we decided, could be a bacteria, fungi, virus, parasite. And once you have that, you need to have a certain compromise in the barriers that we talked about, unless you have an organism that can go through an intact barrier. But even if the organism can pass through an intact barrier, it must be able to establish itself somewhere nearby, as we talked about in the case of Neisseria gonorrhea causing a hyperacute bacterial conjunctivitis. So either way, causative organism has to go through the epithelium either by destroying it or by directly penetrating it to basically start the inflammatory cascade once it reaches the stroma and it produces an ulcer. Because remember, ulcer formation is able to incite a very strong inflammatory reaction. And then you have the signs of acute inflammation that we'll see, and we'll figure out how they come about. And they include circumcorneal congestion, infiltration, ulceration, abscess formation. And the interesting thing is, and we have talked about it before as well, that the cornea is avascular. So if it is to go through an inflammatory process, it must have some way of recruiting inflammatory cells. And we have talked about some of those sources. One was conjunctiva. Two was the cornea itself, because it has those Langerhans cells and dormant immune cells. And there is the limbus also. Remember, limbus is a transition zone between the cornea and the sclera, and the conjunctiva begins from there. So the limbal vasculature is a very important source, as is the anterior chamber, because the anterior chamber has aqueous humor in it, which is right by the iris. In the anterior chamber is the space between the cornea and the iris. So the iris has a lot of vasculature in it. We'll study or talk about iris vasculature when we talk about uveitis. But so all of these sources can provide immune help or assistance to the cornea. So you have limbal vasculature, you have your anterior chamber, you have your conjunctival vessels, and if your infection is bad enough, your cornea can start getting vascularized. Remember VEGF? We talked about VEGF a lot when we were doing gradual painless loss of vision, diabetic retinopathy, age-related macular degeneration. The same VEGF released from compromised corneal stromal cells can also incite new vessel formation onto the corneal surface. So once you have all of this inflammatory cascades initiating, you have stromal destruction. Stromal destruction is because of the organism that is invaded and also because of your defense cells, because your defense cells, together with destroying the organisms, can also destroy your own tissue. Remember, inflammation is a dual-edged sword. It helps, but it also destroys your own tissue. And I think those of you who have done pathology really well should be able to, or should know this better than I do. So once you have stromal destruction, you have the abscess formation, and we'll just see how all of these things appear. So how does a patient who has keratitis present? Well, the patient is going to present with a painful red eye. The pain has multiple causes, and we'll see why that is, with photophobia, together with blurring of vision, watering and discharge, together with a history of an inciting event that would point towards how the organism came about to be in a position to cause a keratitis. The most common event is a trauma, which damage epithelial barriers, or actually also in addition introduces the infective organism. And the various types of trauma are contact lens use, contact with contaminated items, including washroom taps, kitchenware, machinery. Remember, agrarian economy, agricultural equipment. Together with, there's another infected part of the body, and you're just bringing infection into your eye by touching that part. You can also have a history of primary viral infections. If we are talking about a viral keratitis, remember, it's a secondary infection that causes a keratitis. And any prolonged ocular infection, for example, a nicereal conjunctivitis. So you have a history of an event that would lead or tell you that, yeah, this was the point where the cornea became compromised, or the process of inflammation started. And although the history can point you towards one potential source, you cannot be sure, yeah, this is the organism, or this is the type of organism, for example, a bacteria that has caused it. Only a culture and sensitivity can tell you that, with the possible exception of a viral keratitis, and we'll see why that is. So now we're going to see actually how the organisms come to the eye, how do this initiate the damage, and how does the inflammatory cascade start? Well, the first thing that we decided was that you need a defect in one of the barriers, and that defect in the barriers would allow the organism to actually start the process of invading the cornea. And here we have an epithelial defect that provides a way for the infective organism. And right now, they can be anything. They could be a fungus, it could be a bacteria, it could be a parasite. Viruses have a slightly different way of coming into the eye, and we'll talk about those in a bit. But this could be any organism. And once you have the defect, the epithelial defect, it is able to penetrate into the corneal epithelium. And right now, this is an abrasion or an erosion. It's not an ulcer, because the defect exists above the basement membrane of the epithelium. So once you have this defect, and obviously we talked about Neisseria and some other organisms being able to penetrate without the defect, the organism would replicate and increase its number. So this is the stage where it is insidiously increasing its number so that it can mount a larger attack onto the stroma. And right now, your body's response is sort of muted because of the location of the organism within the epithelial regions. So what would happen then is that this defect would become bigger and convert into an ulcer by damaging the epithelial basement membrane, and now the organisms can penetrate into the stroma. And this is the point where an ulcer is formed, because the defect has now extended beyond the basement membrane of the epithelium. And the organism is now quickly able to replicate in the stroma because it has such a lot of things to thrive on. And here, at this point in time, what you start getting is your circumcorneal congestion right here as one of the sources of inflammatory cells. Remember, we talked about limbal vasculature, and that is right now getting inflamed in response to vasodilation from this inflammation that has started within the stroma. So you start seeing redness in the eye, and that is the first thing that happens when the inflammatory cascade begins. You have those inflammatory cells coming in. For that, you need vasodilation. And the closest source of a lot of protective cells is one of the closest source is your limbal vasculature, so it dilates. Together with that, you have other support cells coming from the anterior chamber, as well as these cells from within the cornea itself, those Langerhans cells and those lymphocytes, and all of these sources from dilated limbal vasculature from the anterior chamber and also from within the cornea, all of these protective cells and the exact nature of this cell would depend upon the inciting organisms, but it's most likely to be a neutrophil, and they would come here, and you would have the inflammation proper beginning. You have release of all of those enzymes and other agents that would cause destruction of not only the organism but also your defense cells, and that would lead to formation of an abscess. An abscess is a localized collection of pus. So now we have an ulcer, we have circumcorneal congestion, we have an abscess formation, and we also have infiltration in form of these defense cells coming in from the various zones, the circumcorneal congestion, the anterior chamber, as well as within the cornea. So this, we'll see how it appears in a real eye. So this is a normal picture of a normal cornea. This is the flash, and this is how a normal cornea appears. And this basically is an appearance of a keratitis. And we can correlate or compare the lesions we saw in the animation to the lesions in the eye. This is circumcorneal congestion. It is also called circumciliary or limbal congestion. And rather than the congestion of conjunctivitis, which was very diffuse, the inflammation that you see, or the congestion that you see is more limited to around the limbus, because the tissue that's being damaged is the cornea, and the closest source of vasculature is the limbus. So as you can see, even in this picture, the congestion or the vasodilation or hyperemia is the greatest around the limbus. Then you have some clearing zone, because this is where most of the protection is needed. This is your infiltration, this slight haze that you see in the cornea. These are all the defense cells coming in here. And this is the abscess, this creamy lesion is where all the action is taking place. Now you might wonder, where is the ulcer? And the ulcer is usually below this abscess, and it's usually not visible unless you stain it. There are times when you take a picture and the edge of an ulcer is visible. I'll show you some pictures, but you need to stain it in order to actually see the ulcer once you have a picture like this, in order to get a good idea where or how much are the boundaries of the ulcer. One thing that you might notice is this pupil doesn't look right. Is it bigger or smaller than normal? And if you are a betting person, what would you say, and how would you explain the size of this pupil? We'll talk about the size of the pupil and its relation to keratitis in a bit. So this is another one. Let's see if we get our bearings right. We need to have some redness, and that redness has to be around the cornea. We need to obviously have the abscess. We need to have that infiltration. So these are the three things that we have talked about so far: abscess, infiltration, and circumcorneal congestion. Circumcorneal is also called circumciliary or limbal. They're all the same things. This is the infiltration, the area between the white and the creamy colored outlines. And this is the abscess, where the action is taking place, where the actual destruction is taking place. And if you see carefully in this picture, this is the edge of the ulcer. And if you look at the pupil, this pupil is much different than the pupil we saw before. So which one's normal, this one or the one that we saw before? And why is there a disparity in pupillary size? So this is what we have seen so far. We have seen redness, we have seen blood. We have talked about, these are the symptoms that we talked about. Now we're going to put some reasons around it. We saw redness in our patient. Patient is complaining of blurred vision, pain, photophobia, watering, and discharge. So why are all these things happening? Well, redness is simply an inflammatory response, and it's around the cornea because the inflammation is within the cornea. Remember, we call it circumcorneal, circumciliary, or limbal congestion. Blurred vision is because of ulceration, infiltration, and abscess formation, preventing light from reaching the retina. Pain and photophobia. Pain, as we talked about, has multiple reasons. Tear film disruption, simply because of the inflammatory processes, together with rubbing, together with the fact that you have a defect where the tear film cannot interact properly with the cornea. Irritation of the free nerves through the ulcer. Iris spasm, that is why there was a disparity between the two pupillary sizes. Remember, one of the sources of inflammatory cells is the iris. And if the iris is releasing, the vessels within it are vasodilated, that means there is effect of inflammation on the iris. And those inflammatory mediators, prostaglandins released, they act on the sphincter or the pupillary constrictor, and it constricts the pupil and makes it smaller. It acts on the smooth muscle. Well, you would say that the dilator is a smooth muscle. Why doesn't it become dilated? Well, simply because the constrictor or the sphincter is much more stronger than the dilator muscle. But why was there a disparity between the two pupillary sizes? Well, the picture you saw first, the one with the dilated pupil, was actually taking some medication to release this iris spasm so that the pain could be reduced, and the second patient wasn't. Pain can also be because of the skin lesions if we talk about herpes zoster ophthalmicus, and we'll see how those appear. Watering and discharge is the inflammatory reaction together with your rubbing, and that is why you have watering and discharge from the eye. So we have seen the signs. Let's summarize them. We saw circumcorneal congestion as a source of inflammatory cells for the cornea. We saw ulceration, where was the point of entry and abscess formation. We saw infiltration, that's just the protective cells coming in to defend the cornea. We saw constricted pupil, which may be seen if the iris is spastic simply because of the contribution of the anterior chamber to the corneal inflammation. If there's a lot of inflammation in the anterior chamber, you would see a small pupil, as we saw in one of the pictures in which the iris spasm was being treated by giving a mydriatic agent, something to dilate the iris to relieve the pain. And although a history together with your own clinical acumen and competence, you would be able to probably pinpoint the organism responsible for the keratitis, it is nigh on impossible or very difficult to say this is bacterial or fungal. Viral, yes, you can say. Parasitic, yeah, maybe, but it's very difficult to say it's bacterial or fungal without actually getting a culture and sensitivity done. Why is this important? We'll talk about management and we'll come up to the point. Why is it so important to differentiate between a bacterial and a fungal keratitis with regards to the management of your patient? But before we go on to that, we have one more thing, and that is, what if your condition starts worsening? And that would happen because either the patient is not taking treatment, your treatment is ineffective, the patient never presented earlier, and it only presented when things got worse. And you were immunocompromised, or your patient was immunocompromised, and when you started the treatment, you didn't think of it. You didn't think of diabetes as a possibility, and you just started the treatment thinking it would work just as well as it would in a normal person when your patient is a diabetic. So the things that where we left our eye off was circumcorneal congestion, abscess formation, an ulcer, obviously, and infiltration. And we're going to move our story forward from that point in time. And the thing that will happen is that the organisms that and your defense cells that are in this abscess, they would sort of start collecting in your anterior chamber simply because there are too many of them. And remember, right now they are dead. And they would form a little pool of dead tissue, which is called a hypopion. A hypopion is basically a sterile pus which collects in the anterior chamber. We have seen hypopion before when we talked about endophthalmitis in relation to complications of cataract surgery. So the dead organisms together with your dead inflammatory cells start pooling in the anterior chamber and give rise to something called a hypopion, which is basically pus in the anterior chamber, which right now is sterile. You can also get infected pus if the organism is able to get inside the eye, like in the case of an endophthalmitis. The other thing that would happen is, as we talked about before, in relation to what the cornea can do to get some vascular support, is that when the cells within the cornea die, they release VEGF, and this VEGF can act on the closest source of vasculature, which is the limbal vasculature, and produce new vessels on the corneal surface. And this would be again happening on the limbus initially. And these new vessels are called pannus. They can grow bigger to form proper vessels, but the new vessels that arise and are at the limbus, they are called pannus. Different type of corneal vascularization we'll see just in a bit. but it starts off as little twigs of vessels at the limbus, which is called a pannus. So this is another picture, or this is a picture of a keratitis, and we can identify certain things that we have seen before. We can identify circumcorneal congestion, we can identify infiltration, we can identify our abscess formation. The abscess here is not in a single area, but in multiple areas. So this is what we've already identified: infiltration, abscess formation, and circumcorneal congestion. Let's see the two things that we just talked about that are also visible in this picture. One thing is very obvious and staring you in your face is this. This is your hypopion. We're just going to dim this cell right here because remember infiltration we've talked about before. So we're going to bring up hypopion right here. This is that pus in the anterior chamber. It's connecting between the iris and the corneal endothelium, or the back surface or the posterior surface of the cornea. And the other thing we talked about was the new vessels that are forming at the limbus. Remember, these are new vessels. This is not congestion. Congestion was happening at the limbus right here. And these are new vessels that are growing onto the cornea from the limbus. And do you see any here? Well, this picture is here, so there must be some here. And they're right here. These little twiggy vessels. This is how a pannus initiates or begins. And this is going to grow towards this area, where your abscess and your infiltration and your organism and your body's defense cells are fighting each other. Let's look at another picture: abscess, infiltration, circumcorneal congestion, hypopion, and a more prominent pannus. Let's look at another picture. And this time, again, this is your abscess, infiltration, circumcorneal congestion. It's really clear here that the area around the cornea is congested and the rest of the conjunctiva is all sort of not as congested. Very obvious pannus, and then hypopion. And again, the abscess is sort of in multiple locations, not a single area. You have this pannus and you have circumcorneal congestion and then hypopion. So this is what happens when the infection gets worse. And we already talked about reasons. Your treatment is ineffective. The patient is not taking the treatment. The patient simply presented late. It was another immunocompromised state that was overlooked when you were sort of beginning to manage your patient. Before we summarize these additional signs, let's just look at one more picture. And this is a pseudomonal keratitis, a very severe pseudomonal keratitis. And if I look at this picture, I can't really very easily make out the various structures of the eye. I can probably say that this is a light beam coming from a slit lamp, which is used to see this patient or examine this patient. I can say this is the light beam because it continues on to the lid right here. This is probably the cornea. I'm just going to move my cursor over what I think is the outline of the cornea, and it's just all opaque. It's just a bag of pus, a large abscess. This is all the discharge that's on the eye. And the hint that I get that can tell me that what was the likely source of this infection are these linear lines of the cornea. Once a long time ago, really long time ago, I'm talking about maybe 4 or 5 decades ago, that there was this procedure called radial keratotomy, and the idea was to produce linear scratches on your cornea in order to reduce myopia, so you could, get rid of your glasses. And it's not done anymore, or it shouldn't be done anymore. And what happened here was that this is radial keratotomy, and these are your linear scratches done through a very special diamond knife. It's not supposed to be done anymore. The idea was to sort of reduce the steepening on your cornea. And remember, a steeper cornea means more corneal power means myopia. You can go back to refractive errors if you want to review this information. Shouldn't be a requirement because you just started ophthalmology. A review shouldn't be a requirement this early is what I mean. So these scratches on the cornea are actually defects in the epithelium, which can allow an organism to move in, especially if the field, your surgical field where this procedure wasn't very sterile to begin with. So let's summarize those additional signs that we just saw in case of a severe infection or a worsening condition that we decided could be because of a severe form of an infection, keratitis that not managed properly, either ineffective, inappropriate treatment, or a patient that's not taking the treatment, a late presentation of the patient just presented when in a later stage of the disease, or the immune status of the patient was overlooked when the therapy was started. And those were hypopion, the 2 lesions that we saw, Hypopyon was sterile pus in the anterior chamber, which might become infected if the organisms moved inside, which in this case would happen when the cornea perforates and allows entry of the organism into the anterior chamber. The other lesion we talked about was corneal vascularization, which was in response to production of VEGF, which if limited to the limbus is called pannus. If it extends beyond the limbus towards the ulcer or infiltration, wherever the source of the VEGF was, it's called corneal vascularization. So we'll just see what various types of corneal vascularization exist. So this right now is corneal vascularization. This is the feeder vessel producing the corneal vascularization. This is your ulcer, and this is pannus, which limits itself to the limbus. This has been mentioned before that it's very difficult just to look at the patient and look at the process of the keratitis and say with surety, yeah, this is bacterial or fungal. You can say with a lot of surety it's viral, a little bit amoebic or protozoal or parasitic, but otherwise it's very difficult. But there are certain types of keratitis that produces a very specific pattern, and that would help us guide our diagnosis. But before you initiate appropriate treatment, you must follow protocol, and the protocol we'll talk about when we talk about management. So this is an acanthamoebic or parasitic keratitis, and it produces this ring-shaped infiltration, circumcorneal congestion, ring-shaped infiltration, or an abscess. And the other thing that's usually mentioned is that there is a lot of pain, and that's out of proportion of clinical signs that you see. Congestion, infiltration, abscess formation. This is not always true, and it's very, very unreliable diagnostic sign. This is another ring infiltrate, yet another ring infiltration or abscess formation. This is a viral keratitis presentation, a dendritic ulcer, and this is very characteristic of how a viral keratitis appears, and it has this appearance because the virus basically damages the free nerve endings, and it produces very characteristic dendritic shaped ulcers. And at these very terminal ends, these bulbs is where the virus replicates. But these bulbs are seen in herpes simplex and not in herpes zoster. And as the free nerve endings are destroyed, the corneal sensitivity to touch is lost. So the pain that most of these patients experience is because of a destruction of the nerves when they're being destroyed, the exposure of free nerve endings, whatever they are exposed, and iris spasm. This is another picture of a dendrite together with those terminal bulbs. This is another presentation of a viral keratitis. This is called a disciform keratitis, and this usually presents later in the disease. And this is basically affecting the endothelium side of the cornea. This is basically the epithelium and the stromal area. That's why it's an ulcer. And this is basically an area of endothelial inflammation called endothelitis. And it's not an infection that's in this region. It's an immune response to the non-replicating virus particles. And since this is an immune response to a non-replicating particle, it is best managed with steroid under the cover of oral antivirals. This immune response must be suppressed by giving antivirals so that the virus, which is still probably around in the eye, is kept under control while the steroid deals with this part of the inflammation, which is the immunologic response. This is how herpes zoster ophthalmicus presents. So you have your eye signs, which is again a dendritic ulcer or a disciform keratitis, but you also have your skin lesions, which are present along the distribution of your trigeminal nerve along one side of the body. That's how classically herpes zoster presents. And if it's not the eye, in the general body, it's called shingles, where you have those similar skin eruptions along one dermatome, one sensory dermatome. And this lesion right here on the tip of the nose is because of involvement of the nasociliary nerve. So if you see this lesion or skin eruption on tip of the nose, and skin eruptions usually precede eye involvement, you can be very sure that the eye would be involved as well, because this is the nasociliary nerve which supplies this part of the nose, and it also supplies the cornea, the sensory supply to the cornea. So if the virus has reached here all the way from the trigeminal ganglion, it will reach your cornea. One thing that's associated with this is called post-herpetic neuralgia. This is a very painful condition, and it is pain that lasts for more than 120 days from the point where the the rash first appeared, and this is again because of the involvement of the fifth nerve. The post-herpetic neuralgia is a time so bad that the patient have actually thought of committing suicide. Yes, that's actually true because of the amount of pain that they have. So now we're getting into the management bit. And again, as we said, you look at this ulcer and you say viral, not likely, because viral has that very specific pattern. Bacterial, fungal, maybe acanthamoeba, not likely, but I can't say for sure. So we need to come up with a plan, a management plan that works best for your patient. And the first thing to do is to establish a provisional diagnosis in your head. Yeah, this is likely to be this, and that's on the history and your examination. Then you take your specimen for culture and sensitivity, and those are your corneal scrapings. And you don't need to do it if it's viral. You can, if you want to. Viruses can be cultured or PCR can be done, but it's expensive, and viral lesions are very characteristic. But before you take your culture and sensitivity specimen, you need to ensure that the patient is not taking any treatment. If the patient is taking treatment and you take a CS specimen, it would provide no useful information. So the treatment should be stopped. And the reason it doesn't provide useful information is when you're taking treatment, you get a very confused sort of culture sensitivity report, which is telling you that your infection is polymicrobial or you get no growth at all. The amount of organisms required to cause a corneal inflammation is small to begin with, simply because, as compared to the rest of the body, because of the size of the structure. And then you're contaminating it with antibiotics that might allow another organism to grow on it, which isn't exactly causing a keratitis, but just started growing because it can. So you stop the treatment. And in fact, there is no harm in stopping the treatment because the treatment is not working. That's why the patient is coming to you. So if you want to take a culture and sensitivity sample in a patient who is taking treatment, which is clearly not effective, you stop it for 2 days before you start your own treatment so that you can take a CS specimen, a culture sensitivity specimen. Once you have your specimen and you have sent it away for the appropriate cultures and sensitivities that we'll just talk about, you can start your empirical treatment, and it is based on the location of the ulcer. Once you have done that, you can review the patient in light of the CS report. And if the patient is improving, and what will tell you the patient is improving? The size of your infiltration, the amount of redness, the abscess, and pain for the patient. They will all reduce if your treatment is working. You do not modify your treatment if it's working, even if the CS report says you're wrong. You only modify if the treatment is not working, the patient is getting worse, and the CS report says, no, you have to use another antibiotic. You don't modify if things are working because what you see with your eyes is more believable than a piece of paper. The piece of paper could be wrong specimen, wrong disc, expired disc, contamination with another specimen. But what you are seeing with your eyes, a patient improving who's telling you himself he's improving, trust your eyes, trust your treatment. Only trust the piece of paper when what you do and what you see is not working. And you can provide additional supportive measures. Debridement, simply cleaning the wound, helps. If your cornea is getting thin, you might want to support it, and we'll talk about how to do that. And if the pain is something that the patient is still being bothered by, you can talk about cycloplegics, you can talk about oral NSAIDs. But once the therapy actually starts working, the pain is honestly not that bad. So pain is a very good marker of your treatment working, which is the same thing I said when we talked about post-operative medications for your cataract. That presence of pain that is unbearable is usually indicative of a process that should not be happening. Finally, once your infection is done with, we need to talk about how we best handle our post-infective state. And we'll see what we do in that state in just a bit. So remember, we keep saying, okay, we need to get a diagnosis before we start treatment. Why don't we just start every treatment possible? Remember when we said start empirical treatment? Let's start antibacterial, antifungal, antiparasitic. Well, you can't start antifungal or antiparasitic unless you have diagnosed the infection to be as fungal or parasitic. And we'll just say why that is in a bit. So to get a fungal culture, you need to take your scrapings and you do it on one of these agars. You can also do confocal microscopy. I'll show what a confocal microscope is. And what you do is you see the cornea with this special microscope, and you pick up those structures that tell you, yeah, this is a fungus. You can also do a KOH test, which is probably the cheapest and the simplest way of detecting a fungus. You use your spray, put a 10% potassium hydroxide solution on it, put a cover slip, see if you can find a fungus. Do it if nothing else is available. The same is true for amoebicides. You don't start amoebicides for a parasitic infection unless you diagnose the infection to be because of the parasite, Acanthamoeba in this case. And the reason I'll talk about the reason in a bit. The way you do that is, it's a non-nutrient agar plate overlaid with E. coli, and you need to observe it for quite a bit of time, 7 days. You can do PCR DNA, it's pretty expensive. You can do confocal again, like with fungus, or you can take corneal biopsy if everything else is negative. The culture, the DNA, if it's available, and the confocal, if it's available. Why don't we do it? Because both of these therapies can actually damage the cornea and worsen other types of corneal infections. So you don't start these types of therapies unless you are sure that this is fungal or amoebic. These are antibiotic dosing guidelines, and we are starting off with bacterial keratitis. These are guidelines. The actual treatment would be based upon how the patient presents. But generally speaking, antibiotics can be given as frequently as every 5 minutes for the first hour. It's really important to remember for the first hour only, and that also in cases of very severe infection, and then it is sort of reduced to 1 drop every hour. And then it's gradually tapered off depending upon the patient's response. The antibiotics that are available are fluoroquinolones and aminoglycosides. These are available off the shelf prepared, i.e., you don't have to prepare them yourselves. So among fluoroquinolones, moxifloxacin has very good gram-negative activity and good gram-positive activity. Aminoglycosides are again given as fortified drops. That would mean you take a commercially available aminoglycoside preparation and then you put an injectable aminoglycoside in it to increase its strength. It provides very good gram-negative coverage. But the thing about aminoglycosides is it can also inhibit corneal wound healing. So you have to be a little careful, especially regarding its dosing and a little bit of a careful patient follow-up. Cephalosporin and vancomycin are not available as drops, and they are prepared from injectable forms, as given here in the on the slide, as you see. Cephalosporin, cefazolin provides very good gram-positive coverage. Vancomycin is usually used for methicillin-resistant staph aureus or MRSA. It can also be used as an alternate to cephalosporin if the patient has cephalosporin allergy. For diagnosed fungal keratitis, usually, as we have already talked about, usually, no, always, you do not prescribe antifungals unless you know that you're dealing with a fungal keratitis, because antifungals can actually inhibit corneal healing, or even they are keratolytic, so they can damage the cornea, worsening other types of infections. So once you have a diagnosed fungal keratitis, you can use 1 drop every hour. And it is tapered as soon as you start seeing a response, i.e., the inflammation starts subsiding. And how do you know that? Is obviously the decreasing amount of pain and redness that the patient has. We have azoles and polyenes as two common antifungals. Unfortunately, none of them are available in Pakistan in a commercially prepared form, so you have to prepare them from pre-existing injectable forms. So azoles work by inhibiting synthesis of ergosterol, fluconazole in the strength of 0.2% topical. Polyenes cause destruction of ergosterol. An example is an amphotericin B, and it's prepared in a 0.15% strength. For viral keratitis, things are much simpler. For herpes zoster, it is 800 milligrams 5 times a day for 14 days of acyclovir, or in others, similar antiviral. Obviously, it's going to have its own dosing. For herpes simplex, it's topical acyclovir ointment 5 times a day for 14 days. For disciform keratitis, you use topical prednisolone eye drops. The dosing is based on severity of the condition, and they are always given under cover of oral antivirals. You never give steroids alone. For disciform keratitis, you give them under cover of oral antivirals on the dose that's been given here, 800 milligram 5 times a day. For acanthamoeba, we have multiple agents. The first line agents are topical chlorhexidine and polyhexamethylene biguanide. They are both disinfectants, and they are also used as preservative in contact lens solutions. Again, it's 1 drop every hour, and as soon as you start seeing a response, i.e., decreased pain and congestion, you start tapering the medication. Um, you have to take this drug for quite a decent amount of time in order to be totally rid of the infectious organism, which could be up to several months. So the tapering has to be sort of prolonged. Second line agents are diamidines and azoles. The strength are given here. Second line agents are always used in combination. So you use diamidines with azoles. The first line agents can be used by themselves, chlorhexidine or polyhexamethylene bigonal. There are other drugs that are usually listed in books, aminoglycosides and others. We don't give aminoglycosides anymore because they have quite a lot of corneal toxicity and can actually make things worse. So this is a rather elaborate outline plan for management of a corneal ulcer other than viral. Viral is going to come up. So you scrape, do culture insensitivity. If a patient is on treatment, stop for 2 days prior, as we talked about it, and also remember to culture for amoebic and fungal infections. And if it's diagnosed as amoebic or fungal, you start the appropriate treatment, but not without diagnosis. If once you have sent all of your specimens for culture insensitivity, you can start an empirical antibacterial treatment. And obviously, your even amoebic and your fungal cultures will not come back immediately. So you start your empirical antibacterial treatment. And as I said, depending upon where the ulcer is, you can either go for a single drug or multiple drugs. If your ulcer is within 3 millimeters of the pupil, the center of the pupil, then you use a fortified antibiotic drop, which is tobramycin together with either cefzolin or vancomycin. We talked about how we prepared those just a couple of slides ago. So tobramycin is basically for gram-negative cover, cefazolin or vanco is for a gram-positive cover. If the ulcer is 3 millimeters away from the center of the pupil, you can start with a single drug of fourth generation fluoroquinolone. And once you have your culture sensitivity report with you, you review your patient, and if he's improving, which is less pain, redness, and abscess or infiltration size, you continue with the treatment. You don't change irrespective of what your CS says. We have discussed this. If he is worsening, change as or she is worsening, change the treatment as the CS report says. Review in 48 hours. If it's improving, continue treatment, and then think about visual rehab once the active inflammation is all gone. If it's worsening, review your diagnosis and treatment. This is the point where you start thinking of something that you missed. Are you looking at an infective keratitis? Maybe this is a non-infective keratitis. Did we overlook the immune status of a patient? Is our patient a diabetic? Is the patient actually taking the treatment? Is the treatment appropriate? So you prepared those fortified drops. Are they expired? Were they properly prepared? So all of these things needs to be kept in mind and appropriately taken care of. If you start getting a thin cornea at this time, which can lead to a corneal perforation, you need to start thinking about and taking appropriate steps to strengthen your cornea, which would be amniotic membrane transplant, tarsorrhaphy, or a tectonic graft. And we'll cover these in a bit. And then finally, review your patient in about 48 hours again. And if he's improving, very good. If he is still worsening, you can go back to the cycle of review, diagnosis, and treatment. But at this point, perforation and eye loss is something that's inevitable. Thankfully, we don't have many patients that follow this part. Most of our patients do get to the improving part. In my last 5 or 6 years, I've never seen an eye being lost to a keratitis. Before that, I honestly can't recall either way. So herpes zoster ophthalmicus is stained. You see that dendritic ulcer. You check corneal sensitivity. You know it's going to be poor. You start oral acyclovir 800 milligram 5 times a day for 14 days. And if you give it within 72 hours, that post-herpetic neuralgia is much, much reduced. Remember the pain that can cause patients to commit suicide. This doesn't worsen. You just, if it is worsening, just think of a super added bacterial infection or a fungal infection. So do a culture sensitivity again. Most of the time, these patients improve. I have never seen a viral keratitis go down a pathway of an eye being lost. Maybe because our patients, the patients I see, are younger and are proper, maybe immunocompetent, and herpes zoster ophthalmicus, the outlook has changed in the setting of HIV. I have honestly not seen patients of HIV with herpes zoster ophthalmicus, so I know there is a possibility of the disease or herpes zoster ophthalmicus getting really bad, but I personally haven't seen that happen because the treatment is pretty effective if the diagnosis is right. And if it is getting worse, think of a secondary infection or over a viral keratitis, a secondary bacterial fungal keratitis together with viral in a setting of an immunocompromised patient. Why haven't I put up herpes simplex? Because herpes simplex is simply the ointment form of the same thing for 5 times a day for the same amount of duration. And this is obviously the management of a dendritic ulcer. For disciform keratitis, again, we add steroid over oral treatment. So just to cross the T's and dot the I's, herpes simplex, topical acyclovir 0.5 times a day for 14 days. And disciform keratitis is oral cyclovir 800 milligram 5 times per day, 14 days, plus topical prednisolone 1% for herpes simplex or herpes zoster. This is just to cross the T's and dot the I's. This is Staph aureus. These are fungal hyphae. And this is confocal microscopy. So this is the confocal microscope, and you see amoebic cysts like these. These are really hyperreflective lesions that you see. And it's actually the amoebic cysts that are more difficult to get rid of. The trophocytes are responsive to most of the anti-amoebic treatment. It's these cysts, the inactive forms, that need to be completely eradicated in order to get rid the patient of amoebic keratitis. Now we'll talk about post-infectious rehabilitation of a patient. What to do when the patient's inflammation is gone, the scar remains, so we need to think about how to improve his or her vision if it's required. The issue with vision after a keratitis is the corneal scar. Remember, ulcers always heal by scarring, and depending upon where the ulcer was and how much was the damage, the location of the scar and the density of the scar would determine how much of a loss of vision has taken place. Obviously, you would know that you are in a post-infectious phase when there is no sign of inflammation, and I'll show you some pictures. This and this, they are both corneal scars. They are not infiltrations and abscesses. There is no congestion, no congestion. Large scar, small scar, but no congestion. So these are the various grading or ways of grading scars. This was really popular once when the entire management of an ophthalmological issue was primarily with a torch, not with a slit lamp. So the grading of scars was nebular, macular, and locomal. A nebular scar is a faint scar, and you can see through this opacity. A macular scar is a scar that is dense, you can't see through it, but it's not one homogeneous scar, there are clear spaces in between. And a leucomal scar, leukoma from white like leukocytes, is a dense scar which has no clear spaces between it and you can't look through it. So of all of these three patients who have recovered from infectious keratitis, which one do you think would have the best vision? And it's not a very tricky question. Obviously, this patient has the clearest visual axis. The scar here is less dense, but it is more on the visual axis than this scar. So this person would have the best, this after, and this the worst. This patient has a little bit of a cataract, but if the cataract wasn't around, he would have, or he would still have a relatively worse vision than this patient, the one in the middle, simply because most of his visual axis is clear. So cataract right now is not taken into consideration because even if this patient, the one on the left, did not have a cataract, his vision will not be as good as this patient whose picture is shown in the middle, simply because the scar, even though it's less dense, is still on the visual axis. So scar, keratoplasty. You need to replace the cornea. We've talked about keratoplasty, discussed this in a level of detail, seen a video as well when we talked about vernal keratoconjunctivitis, keratoconus, in context of keratoconus, in the setting of vernal keratoconjunctivitis. And the same principles apply here. But you cannot do keratoplasty in an actively inflamed eye because you are opening up the eye and you're allowing the infection to go inside the eye then. You would lose the eye. It's always post-infectious visual rehab. What about the complications of an infective keratitis or infectious keratitis? One we briefly touched upon was a corneal thinning, and the other one is going to be as a consequence of corneal thinning. So this is where we left off our discussion of keratitis at stromal destruction and abscess formation. And these are the things that happened that led to a successful management and management of post-infectious visual issues. This is what would happen if things are heading towards a complication, your treatment is still not working. The patient is actually presenting at this stage, which is a much later stage. So what would happen is your cornea would have thinned extensively and thinned so much that only the Descemet's membrane has left behind. All the stroma and the epithelium has been destroyed. This stage is called the desmatostele stage. This desmatocele is the only thing that's preventing those organisms from entering into the eye. It's like, you play one of those zombie games, and you have one of those, what are they called? Castle defense games or tower defense games, and you build this really complicated tower or walls around it. So what's happened right now is only the last barrier is remaining, and those zombies are just about to get you. So imagine those walls or those barriers as layers of the cornea, and those zombies as your infectious agent. There's only one little barrier left, and all the zombies are coming, and all the infectious agents are just going to be right around there. And once you have your corneal perforation, things inside the eye go outside, and the organisms from outside come inside, and you end up in endophthalmitis, which is basically the end of the eye. Although we'll talk about certain things that can even be done once a perforation has taken place, but essentially you're looking at the end of the eye. The end of the eye would mean end of useful vision in the eye. Why does a patient end up in a complication or a complicated state? There are many reasons, and this would apply to most diseases, not only keratitis. And the first is the patient simply presents late. He presents at a stage where the complications have already set in. The reasons could be doesn't have the resources, no hospitals around, no one to take him, even if resources are present. And I know of a patient whose entire family was living in the US, and she was a patient of open angle glaucoma, and she did not come for her regular consult for a pretty long time, years. And when she finally came about, she said there was no one to bring me. And she was living about a kilometer away from the hospital. And she said, there is no one to bring me. There's no one home. How would I come here? It's very difficult for me to get out of the house. These things do affect the patient's ability to seek help. The other one is ineffective treatment. And there are a lot of factors within this category. The first is the patient does not take the treatment. Perhaps the doctor did not communicate effectively. He just wrote a prescription, say, take this, and he was like, what? He does not have faith in the treatment. Many times that is also true. Or the treatment was just simply too expensive for him. In spite of the fact that we have a lot of public hospitals, they do not provide a lot of treatment or medications for free to the general public. The treatment is incorrect. Your diagnosis was incorrect. The prescription is incorrect. Either you made a mistake in writing or filling, or the drug simply does not act. Poor quality drug. Effect of alternate medicine, and this is really important, and I can recall two patients. One who came up with not a keratitis, but a simple stye, an infection of the hair follicle. And it's a very simple thing to treat. Gave her the treatment. 4 days later, came up with a severe keratitis. It was something like the picture of the pseudomonal keratitis I showed you. And I couldn't understand what had gone wrong. And the patient just said, I took the treatment you gave me. The patient kept on saying that. And a good 10, 20 minutes later, I talked to the attendant alone without the patient and asked him, look, there is something wrong. You need to tell me what it is. He said that her husband took her to a local faith healer who fried some powder, didn't know what that was, fried some powder and applied it to her eye. She was screaming at the time, and the faith healer said, just take her home and she'll be fine. And this was just a day before she came to us. And the cornea was entirely, there wasn't a keratitis, the cornea had actually sloughed off. That reaction that we were seeing it wasn't an infective keratitis, it was a non-infective severe inflammation because of the burn. Terrible. The other is not so much a case of an alternate medicine, but rather a case of self-medication in which a patient was using topical anesthetic drops in order to get rid of a foreign body sensation. And he found them to be effective. They are amazingly effective. You don't feel anything. He couldn't feel anything. He kept rubbing his eye. He kept rubbing his eye. Eventually ended up in a keratitis. We gave him treatment for a keratitis. The treatment never seemed to work as well as it should. And we were very sure we were right. We got the culture sensitivity done, everything done. We were on the right track. It wasn't working. Sent the patient out, talked to the patient's wife. She said he still uses the lubricant, the anesthetic when we told him to throw it away when he came to us initially. But he had so much faith in that bottle of Alkane because it made all his pain go away, even the pain of the keratitis go away. He lost his eye eventually. Patient is immunocompromised and you missed it. And this is a slit lamp picture. This is the light coming from the iris and the lens, light coming off the iris and the lens. This is coming off the cornea. You can see the central corneal thinning in an area where desmatocele would form. This is a normal corneal thickness. So this is the area in which a desmatocele would eventually go on to form. Let's see how these complications develop. So we left off our patient with an ulcer, an abscess, corneal vascularization in the form of pannus, or maybe even proper vascularization, circumcorneal congestion, hypopion formation. And what is happening now is that with time, this abscess is getting bigger, and its abscess is getting bigger for all the reasons that we talked about, and some of them are replicated here. And the stroma is getting thinner and thinner simply because it's getting replaced by the abscess. And a time would come that all of the stroma has pretty much been destroyed, and the only thing left is that Descemet's membrane, which is being pushed from inside by the intraocular pressure. So this red arrow is showing us the area of the cornea, which is just the Descemet's membrane. Around it, we have a little bit of stroma left, but in this area, it's just the Descemet's membrane, and this would be pushed out by the intraocular pressure. And this is called a desmatocele. This is how a desmatocele appears. This is in a patient who has had a healed ulcer, but it's difficult to see, but you can see how there is a sort of a convex elevation of the cornea here. You can tell it how the light bends around it. This is how it would appear in a cross section, but this is again a picture, not a diagram, sorry. This is a histological section of the thinning. You can see that rather than the entire stromal thickness, you just have the endothelial lining remaining. Now that we are at a point where the cornea either has excessive thinning or desmatocele formation, we need to prevent perforation. Desmatocele especially represents a very weak area that can perforate with continual inflammation or even slight mechanical effect rubbing your eye. So we need to strengthen the cornea, and there are basically two ways about it: graft or tarsorrhaphy. Graft is to produce something on the cornea, either an amniotic membrane or a tectonic graft. Tectonic is a piece of tissue that is placed over the cornea in order to prevent underlying thinning or desmatocele from perforating. Tarsorrhaphy is stitching your list together. Let's see how this happens. So this is an amniotic membrane. Obviously, you get it from the placenta, and you make sure that the mother does not have any infections. You take your placenta, take the amniotic membrane, wash it in a concoction of antibiotics, dry it out, and then apply it. Ideally, you should take a commercially prepared one, which has been through all these tests, but most of the time, it's available in Pakistan, though, in Pindi as well, locally prepared. You have to take permission from the mom to use the placenta. So once you have the amniotic membrane, you stitch it, and it sort of withers away in 1 to 3 weeks, but the stem cells within the amniotic membrane heal the area of desmatocele or corneal thinning, and it's very, very effective. The other thing to do is to put a tectonic graft. Slightly more difficult because you need a donor tissue, either a cornea that's no longer viable or a piece of the sclera that comes with the donor cornea, so you can stitch it here. But it does the same thing. It provides support, but amniotic membranes usually work better. Finally, tarsorrhaphy. Tarsorrhaphy is stitching your lids together, and it's usually done after you've done amniotic membrane or tectonic, and just to prevent the effect of rubbing from damaging the tectonic graft or the amniotic membrane. And we use the ends of a drip set. These are just the rubber things or the rubber portions of the end of a drip set. We put them here past the sutures. We don't pass the suture through the lid, so the suture doesn't simply go through the lid. And we leave a little bit of space on the lateral side so that the patient can put some drops into his or her eyes as required. In spite of your best efforts, it is entirely possible that desmatocele eventually ruptures. The infective organisms move inside the eye, And as the eye decompresses, things within the eye, like the iris, which is a very flimsy membrane, remember the iris is just like this, can actually move out of this perforation. So this is the point where the endophthalmitis has begun to set in, the infection has moved inside the eye, and now you have inflammation inside the eye, which implies that you have lost the eye. So this is a perforation of a corneal ulcer, and you can see that the iris is extruding through the perforation. This is another one in which the iris is expulsing out or coming out of the perforation. At times what happens is that the perforation is when it's really small, comparatively small, and because we've already talked about that the intraocular content expels out because the intraocular pressure is higher than the atmospheric pressure, and it is dragging things out as the infectious organisms are coming in. The iris actually plugs that perforation and forms something called an adherent glaucoma, which is good because although the iris is not in its place, the perforation is self-sealed, it's plugged, which would prevent infections from moving inside the eye. This is endophthalmitis, and this is a corneal perforation shown by the white arrow, which has allowed the organisms to move inside the eye. It is managed just like the endophthalmitis of cataract surgery, intravitreal antibiotics, vitrectomy, in addition to all the topical therapy that we've been doing. And we also saw how a B scan helps in the diagnosis of endophthalmitis, especially if you can't see anything beyond the cornea because the cornea is hazy because of infiltration, abscess formation. And this is what you would see, a lot of opacities together with membrane formation, which would tell you that there is an infective process within the vitreous. We've seen this picture before when we talked about endophthalmitis in context of cataract surgery. Not the exact picture, but a B scan of an endophthalmitis. So the perforation has happened. Can we do anything? Yes. If the eye has lost its vision, there is no vision post-perforation, we need to prevent the infection from spreading any further. Remember, you have intracranial contents that can be affected by that infection that's moved inside the eye. For that, we do something called evisceration. Evisceration is basically scooping all the contents of the eye outwards, leaving only a scleral shell behind. Remember, endophthalmitis is inflammation of all the layers of the eye except the sclera. If by chance there is some useful vision post perforation and there is still hope because enough time hasn't passed, the patient was really following up very quickly and the endophthalmitis hasn't settled in, or even if it's settled in and if there is some vision, aggressively manage the endophthalmitis, seal the perforation by something called corneal glue patches. Fibrin is the most common one used because it's biocompatible, biodegradable, and you clean your site because the fibrin won't stick to debris, and you apply the fibrin patch to seal the perforation. If you have controlled things so far, you can try C3R to kill the organism causing the keratitis. There isn't much evidence for it, but that ultraviolet light, which is essentially destroying cornea. Remember, we talked about C3R when we were talking about keratoconus, reforming corneal crosslinkings. There isn't much evidence that this process does destroy the microbials, but not much evidence does not mean there is no evidence. This is how a corneal glue patch looks like. We'll see a video of this as well. So this is a video demonstrating a corneal glue patch. The first thing you do is to create your patch, which is created out of this transparent sterile surgical drape. You use a punch to cut out little discs. It's difficult to see here, these little discs, because they're transparent. You'll get a better view once it's applied to the eye. This is our perforation, and this larger area around it is the ulcer. So what you do is you take a cotton tip applicator, one of these things, and what you do is you put a little bit of ointment on it, Polyfex ointment, so that it becomes a little sticky, so it can pick up those little discs that the doctor cut off initially out of the sterile surgical drape. Here we go. He's picking up one of the discs and he's putting it in the glue. Now, we talked about fibrin glue as being biocompatible, biodegradable in the preferred solution. This is not fibrin, this is actually cyanoacrylate. Cyanoacrylate is a synthetic material. It can also be used to create a glue patch. So now that the
glue has been applied to the undersurface of the disc. It's placed over the site of the perforation, and the site has to be clean or the glue won't stick to it. And this is the end result, just coming up. It's just being properly placed, and this is the end result. This is that disc, the disc that I was talking about, that was punched out of the sterile surgical drape, placed over the area of the perforation. And a bandaged soft contact lens is placed over it. A bandaged soft contact lens is a contact lens which acts as a sort of a bandage so that this stays into place until it sort of, appropriately sticks. The patient, in spite of the fact that you would warn him not to rub his or her eyes, she or he would do it. So this is just something to keep the patch in place. So this is how a corneal glue patch is applied.
And this is how evisceration is performed. We'll talk more about evisceration when we talk about eye trauma, but essentially involves cutting the cornea out, which allows you access to the intraocular content, taking a scoop, removing everything, putting an orbital implant, which is inert, so that the eyeball is able to maintain some shape. That's important because you want to put a prosthetic eye over it. If you don't put this implant, the scleral shell would eventually collapse. So whatever implant you put would fall posteriorly. And what you do, you stitch the conjunctiva over it, and then you can put an artificial eye or a prosthetic eye afterwards. This is how it would look once you have cleaned the eye from inside. This is where the cornea was been cut. So you put the implant inside this and stitch the cornea over it. Just a few words about non-infectious keratitis. The type of non-infectious keratitis that will be our focus today is called peripheral ulcerative keratitis. Non-infectious keratitis is any corneal inflammation with no known infectious etiology. A peripheral ulcerative keratitis is a type of non-infectious keratitis occurring in the periphery of the cornea, which is either unilateral or bilateral, very strongly associated with autoimmune disease, especially rheumatoid arthritis. How does the corneal ulcerative process actually take place is not very well understood. There are other causes of non-infectious keratitis in addition to peripheral ulcerative keratitis, including trauma, vernal keratoconjunctivitis we have talked about. Trauma we'll talk about when we talk about eye trauma. Contact lens induced sterile keratitis is you sleep with a contact lens, it damages the cornea because of hypoxia, you develop little areas of sterile inflammation, you treat them with topical corticosteroids. And superior limbic keratoconjunctivitis, something that is seen in thyroid eye disease, so we'll talk about it in reference to thyroid eye disease. So a peripheral ulcerative keratitis presents as a red painful eye with a peripheral corneal ulceration, foreign body sensation, photophobia, with a history of an autoimmune disease, especially rheumatoid arthritis, and usually happens in females, usually appears like this, keratitis together with some level of inflammatory exudation and new vessel formation or pannus formation. This is the same lesion ulcerating together with the pannus formation. Here the ulcer is not as pronounced as it is here. And basically, you need a rheumatologist concern simply because it is happening because of an underlying autoimmune disorder, of which rheumatoid arthritis is the most common. Mucolytic agents are very good because they enhance corneal healing, artificial tears, especially the non-preserved variety. Methotrexate is very good for controlling corneal inflammation, as are topical non-steroidals. Steroid drops are sort of relative contraindication because they can actually cause a lot of corneal thinning. So this we have done and looked at before. This is just for you. It's a red eye differential. This is something, or those signs and presentations that are easily visible from a torch, or you can get from talking to a patient. Use this to your advantage so that when you see a red eye, you are able to differentiate by doing very simple things rather than waiting for somebody to show you the patient on a slit lamp or something. Thank you very much for your attention and your time. Please ask questions on your WhatsApp group if you have any.